10 years ago, Peter was young.
Was this the Peter that died?
Peters,
I don't know.
To work on mesothelioma in New York. And at that time, we asked why we want to work on mesothelioma. I've never heard of it. And the past decade, Peter has grown old together with us. And he has established himself as one of the leaders in the arginine deprivation field. He has made a lot of progress, not only just in mesothelioma, but then also in non-small cell lung cancer, and a lot of other areas as well. He published a lot of very valuable publications for us for the ABI project. To that, we are greatly indebted to Peter. And today, Peter is going to talk to us about the mesothelioma work that we talked about last time, and that we initiated a global phase 2-3 study for this cancer already. So here's Peter.
Thank you very much for that very generous introduction, Paul. I'm also very grateful for the invitation and also for the years of collaboration with Polaris, which has been great. I think this is my fourth trip to Taipei, so really very excited by the symposium today. So I'm going to basically spend most of the time on the current data in the TRACTOR trial. I presented the outline 2 years ago. I think we just enrolled our first patient on the trial. I'm glad to say we've now moved on with all the expansion cohorts, 50 plus patients worth of data. I just want to take you back to mesothelioma, because this was really my introduction to arginine deprivation in ASS1 when we published on this area exactly 10 years ago, showing that ASS1 was lost in about 50% of mesothelioma. So why is this a particular interest for the UK and Barts and actually globally? Well, it is, in terms of deaths, the highest cancer mesothelioma in the UK for globally, 2,500 deaths per annum from this disease. We've taken over Australia and various other countries in recent years because of the large amount of asbestos that was imported into the UK. Of course, asbestos is still being used in various countries in China, India, Brazil. So with the long lag time for development of mesothelioma, there will be expected peaks in the next several decades. It also has a very high insurance burden, estimated to be about 200 billion, and certainly patients, when they get their compensation, are paying for recent treatments such as immunotherapy for mesothelioma, which is not yet refunded. Trials are still ongoing in that area. And as I mentioned, there's only one treatment approved first line, and that's a combination of platinum with antifolate, usually pemetrexed, which gives about a 2 to 3 month survival benefit. Most patients die from mesothelioma within 12 months. So we started the monotherapy trial with ADI back in 2011. It recruited over 200 patients were screened, and around 70 were enrolled onto either ADI monotherapy or best supportive care. Pleased to say this paper will be in press in August, September, and we showed an improvement in PFS from 2 to 3.2 months, which was statistically significant with a hazard ratio of 0.56 and a p-value of 0.03. Overall, in terms of looking at ASS1 loss, and we looked at this prospectively, the ASS1 group had a much more inferior outcome. You can see those are the patients who screened ASS1 negative who were treated or were in the best supportive care, didn't receive treatment. And these are the patients who are ASS positive. They had a much better outcome. In fact, that is the sort of data you expect to see at approaching 5 years, less than 10% survival at 5 years from mesothelioma, and actually fits very nicely with the ASS1 positive group, which again speaks to the fact that the data that's out there, that ASS1 negative is a poor prognostic marker in cancers generally. We didn't show in the prospective trial improvement in overall survival with ADI monotherapy compared to best altogether. The trial was not powered for that. However, if we look at the degree of ASS1 loss, and our cutoff for entry was 50% or more negative cells, and you look at the upper quartile of 75 to 100% ASS1 loss, there was actually a significant improvement in overall survival. The p-value that dropped to 0.22 for this particular patient group. Of course, this is a post-hoc analysis, but in the overall population, there was no improvement in overall survival, but not powered for that, as I said. So that was the background to the monotherapy. And we were already, as the trial was coming to an end, proposing a combination treatment based on laboratory data showing that arginine deprivation with API-PIC20 leads to a significant reduction in thymidine, de novo synthesis of thymidine, but also salvage of thymidine, as shown in these experiments. And we looked at this also in vivo and showed that with just one dose of ADI-PIC20 in this mouse model of a bladder cancer, 24 hours, we showed a very nice reduction in FLT uptake. Again, showing that actually ADI is very effective at modulating specifically thymidine synthesis, and provides a rationale going forwards for combining ADI with antifolates, and indeed in the mesothelioma model cell line and also in a bladder cell line, there were additive or synergistic effects of combining ADI with pemetrexed. We looked at this in vivo, also in the bladder model, and again in this situation had an additive effect. You can see ADI monotherapy actually had a substantial reduction in tumour size, but with the combination there was a further reduction in tumour. And again in the FLT-PET combination studies we showed that the combination was more effective in terms of predicting response, and again in vivo showed reduction in the imidate synthase and dihydrofolate, reductase and TK1 enzymes. So this led to the rationale for the phase 1 trial, and there was some preclinical data also suggesting that because of heterogeneity, ASS1 positive clones which had lower levels of imidate synthase were more sensitive to platinum, and the auxotrophic ASS negative cells were more sensitive to the combination. So this was the rationale for the trial. And also, you may have seen at the end of last year in Nature from Ayelet Erez's group, Weizmann in Israel, a study again pointing to this role of ASS1 in modulating. So when ASS1 tumours lose ASS1, this actually leads to upregulation of pyrimidine synthesis in these tumours. They also looked at melanoma and sarcomas in this paper and various other data sets, again adding to the data that's already out there, that aggressive tumours lose ASS1 and this leads to an enhanced proliferation. Also, I should say that earlier this year, Ralph Bueno's group from Harvard had a very large deep sequencing study on mesothelioma, which I'll come back to. But in that study, they showed that the very aggressive type of mesothelioma, sarcomatoid tumours, compared to the less aggressive epithelioid tumours, of which there are also subtypes, but nevertheless, if you just look at those two tumours, ASS1 was much lower in the sarcomatoid group. So we designed TRAP, combining ADI with pemetrexed and cisplatin in a 3+3+3 design, and essentially reached the maximum tolerated dose, which in this case was using 36 milligrams per meter squared, same dose as we used in the monotherapy mesothelioma trial, combined with standard doses of pemetrexed and cisplatin at 3 centres in the UK. So again, in terms of side effects, we didn't really see much in the way of a different side effect profile to what you would expect to see with platinum and antifolate combination alone. There was one patient who did develop an anaphylactoid type reaction, which has been seen before, but that's 1 out of 50 patients. So it's actually less than what we saw in the monotherapy trial. So whether this is the combination of chemo or the fact that patients are getting some steroids as well as part of the chemotherapy, that may explain that much lower risk. So in the first 9 patients, we actually saw a very encouraging partial response rate, and so the disease control rate was 100%, and we had a partial response rate overall of 78%. 5 of the patients out of the 9 had mesothelioma, 4 had non-small cell lung cancer, and it was very noteworthy that of those 5 patients, 4 had the more aggressive subtype, sarcomatoid and biphasic. And in fact, one of the sarcomatoid patients had a partial response, which really was my first patient I've ever seen with a partial response in sarcomatoid mesothelioma when treated with chemotherapy. In fact, some oncologists do not need to treat patients with sarcomatoid mesothelioma because of the very poor prognosis, which is usually around, in the UK, is around 120 days or 4 months of overall survival. So this was the patient who had the partial response with sarcomatoid mesothelioma, had the very classic symptoms of an aggressive cancer, had night sweats, chest pain, weight loss, and really within the first cycle, when he came back for cycle 2, his symptoms